So we're going to have some presentations, firstly on the background to the document preparation, overview of the main points from the document, which will come from TC, and then some plans for future digital solutions, which will be led by Dan and perhaps Graham Robinson if he joins in. So without further ado, I'd like to ask Raman to start the presentation on the background to the development of the guidance. Raman, you're welcome.
Okay, thanks, William. So I'm just going to share my screen, which is hopefully coming up now. So welcome to the webinar on the alerts, guidance, and notifications. And this is a document that has been through a very rigorous process and has been peer reviewed by several boards to get it to the state it's in. And it's an excellent document. I want to congratulate TC on all the work we've done on this. Just by way of background, in 2019, the HSIB highlighted issues in failing communications or follow-up of significant radiological findings. This wasn't unique. This has happened before. And despite many changes and recommendations, we're still having similar issues. The reference case was a woman of 76 who presented ED with chest pain and shortness of breath. Various investigations were undertaken, including a chest X-ray, and having had a diagnosis of a heart attack, she was sent home with follow-up from the cardiac team. The report was then reported formally 12 days later and identified a possible lung tumor. This was sent to ED, where it had been requested, as is the process. A letter and email was sent to the cardiac team and copied to the patient GP, but the letters did not arrive and therefore were not acted on. 3 months later, the patient went to the GP, who accessed the ED tests and saw the X-ray report suggesting a possible cancer, and they were referred then to an outpatient appointment with the respiratory team. But 3 days after that, the patient was admitted acutely with breathlessness and a cancer confirmed. The patient became progressing unwell and died 2 months later. So HSIB launched a national investigation and identified that there was a variation of practice of how significant findings were communicated to clinicians and then how these were acknowledged or not, as the case may be. There was very little assurance that actions that had been indicated previously from the findings had been taken. The recommendations were with the Royal College, with the College of Society of Radiographers, and other relevant specialties through the Academy of Medical Colleges develop, firstly, principles upon which the report of unexpected findings or critical findings and urgent report should be highlighted. A simplified national framework for the coding of these alerts on radiology reports. So we're using the same coding systems, and then a list of conditions. Conditions which would trigger an appropriate flag and request urgent action for those patients. There was a collaborative approach. There was a big team led by TC and the multidisciplinary working party met regularly to establish recommendations. This has been circulated around all the boards of the RCR. And this is a collective consensus of clinicians and clinical radiologists on practices and notifications of unexpected findings, including cancer diagnosis or critical findings that may require immediate or urgent attention. That is the background to the document, and I'm now going to hand it over to William and then to TC to kind of give a bit more meat onto that document.
Thanks very much, Raman. Just before we hear from TC, Max, is there anything you'd like to add to that background?
No, well, I mean, a couple of things actually. I mean, first of all, to congratulate you, because it was a joy to edit. The publications team sits within my department, and just to say on this, you are to be commended. It was admirably short. One of our problems in publishing documents like this is people tend to get behind a keyboard and write 70 pages, and we think, well, nobody's going to read it if it's 70 pages. So we have a thing called the Guildford test, which is basically, can you read the report on the train from Waterloo to Guildford, and that's 32 minutes. And just as a guidance, we just managed it, so it was good. So you're to be congratulated on that. Others we struggle with, but no, it's a really great thing, and we are always up for collaborations on this nature as well. But thanks.
Thanks, Max. That's a fantastic maxim. It's 30 minutes from Leeds to Ilkley, so I should be the Ilkley time. Someone can read something. Thank you. Lynda, anything you would like to add from the SCORE perspective to the background?
Obviously, every opportunity we have to work collaboratively with our colleagues is very welcome, and I think this is a really excellent example of where that's really had a huge effect on the outcomes of this document. We're going to the examples at the end of the document where the innovations in practice are highlighted, I think, are really good examples of that collaboration.
Thank you, Lynda, and many thanks to SCORE for their input. Okay, now it's a really fantastic pleasure to hand over to the colleague who led the work. TC, you're welcome, and we're looking forward to hearing from you.
Thank you, and thank you, William. So I'm going to share my screen. Hopefully you can see this. Okay, so I'm just going to give you a brief kind of run through of the recommendations, and the whole document can be accessed via the Academy of Medical Royal College's website or the RCR website. And the document itself will also be made available via the e-pages in clinical radiology, so that you can have a citation on it and you can review it when required. So as Raman mentioned, there are three main categories that the group has concluded that will require alert. Obviously, in radiology, we report, all spectrum of reporting, and some majority will not require an alert or special notification. But these three categories that will require special notification or an alert would include new cancer diagnosis or newly detected cancer recurrences, critical findings that are time critical, and also significant addenda in the report that may alter clinical management. And the last bit that is important because a lot of the times the report, what have been seen, the original report, what have been seen by the referring team or the clinical teams, and may or may not have acted on the issue, and then we change our findings, and that certainly could be related to cancer diagnosis or critical findings, and therefore that is something would also require special notification. So those three main categories. We'll also introduce a new kind of team member, so a result coordination team. So essentially, their role is to try to help the radiology department, and essentially also help the referring department to make sure that the results or the reports are received and also acted upon, and also to escalate when required. So, for example, when there is a critical findings, and we all know, radiology department very, very busy and sometimes difficult to get hold of the referrals for whatever reason, then the result coordination team could do that on their behalf, not necessarily to convey the actual report, but to let them know there is a report now in a system that that potentially may require intervention and therefore require your immediate attention. And they can also look through the notification system to make sure that the right report has been sent to the right team. And the case that was highlighted and has saved, really is an issue because the report actually went out to another team which wasn't picked up or acted upon, and particularly in multiple teams. And finally, they can also help to identify and escalate imaging alerts. And perhaps, for example, if we set for a 48-hour interval, and if there's not been any action or confirmation of the report have been read or acted upon, then this can be escalated accordingly by the team. And a team does not necessarily need to sit within radiology. It can be part of the trust team, which can also look at or help with other reports, for example, pathology reports, which might require urgent attention. So just very briefly, new cancer diagnosis or new detected cancer recurrences. In the report itself, once you finalize the report, you need to put a text alert, cancer alert, whether you put it at the top of the report or at the bottom of your report or somewhere in the middle, color it or without color it is down to your local preferences and your local practice, but some form of an alert to highlight that this is actually a cancer or possibly a suspected cancer, a new finding needs to be made aware of. And in the recommendation and decision, we also mentioned about the team needs to provide valid contact details, and the healthcare organization must have or ensure a fail-safe system. And importantly, we make sure that this is a responsibility of the healthcare organization rather than just the radiology department or any other particular department. And we'd also emphasize the fact that to make this work, it's likely that the organization will require a combination of a digital system or electronic system, which you'll hear a bit more later, and plus the human interaction, which will be down under the result coordination team. And for critical alert, and the headship requires us to give a list of potential critical findings. So in here, I just summarize what we listed in the document. Bearing in mind, these are all new critical findings. And it might be that one finding is more relevant in one institution, a specialist center, compared to the other. And this can be adapted accordingly to the local services. And this includes pediatric and adult, as can be seen here. And in terms of what to do in terms of critical alert, again, the same thing, highlight the text code critical in the report, and which will be sent immediately via your usual electronic communication to the referrer. If something which intervention or immediate intervention is required, then one should provide a direct verbal communication. And this will be the same, after hours. And therefore, we highlight again the importance of the correct clinical details or clinical contact be made available. And also, this is a time when result coordination team could be very, very useful to locate, for example, surgeons in theaters or the respective team, that will be covering those, the team, another team, to be made aware of the critical reports that we've just made. We received a number of feedback during the consultation period in terms of if we already communicated to the team, do we really need to put another electronic alert, which is not an uncommon practice, in real life. And so it's down to local preferences. And number 6 there, you could see an electronic alert may not be required if verbal communication has been conducted and documented, and that will be subject to your own local governance. And the aim is to reduce kind of interference with the day-to-day work, and also reduce interruption. And then significant addenda, I mentioned that before, and the text code that we recommended will be addition rather than addendum. So this will be, a lot of times, we do addendum for new findings, may or may not be significant, but the addition alert here is to do with something which will affect clinical management. And that could be, new cancer diagnosis that we missed in the original report, or underreported clinical findings, for example. Yeah, so it will be the same for the first and second situations. And if immediate intervention is required, then a verbal communication is also required. And the same thing in terms of the processes. In the document, we also highlighted the roles and responsibility of the clinical teams, very contact, clinical details, and what one can do in terms of multiple clinical teams. So radiology will always send out the report to the referral team. And if the referral team is no longer the primary team looking after the patient, then they should redirect the alert accordingly. And in this case, the coordination team may also be able to help them out. We emphasize the importance of patient communications, and probably best done by the referring team or the clinical team. And I know a lot of trusts, including myself, we have opened up the opportunity to patients to access their own reports or their own records electronically. So if that is the case, we will recommend the IT system to embargo the release of the alert report, or until the referral authorizes release, because you can just imagine logging in and finding out, oh yes, there is a cancer, and that will create a lot of anxiety. And we spend a lot of time discussing this during the on all our consultation and meetings, and this is one of the key features in terms of patient communication. We consulted widely with the lay patient and lay group in terms of what they actually need, and majority of the feedback in terms of whether the patient wants to receive the information that they would like to have access to their reports. They would like to know what is going on. But there is some reservation in terms of, do they do that electronically? A lot will prefer to do it face-to-face, unless they have been educated prior to that, when you access the system, you will see this alert, and subsequent follow-up will continue. So that is something that will need quite a lot of education and support in order for the patient to be able to join electronically to receive those reports. So this is a summary, which I won't repeat again, but essentially we need to prioritize the critical and cancer pathway imaging and reporting. And once we come to the imaging report, then we will have the one of those alerts if required, and then send the report accordingly, electronically, plus minus verbal communication required, and then make sure there is acknowledgement or documentation that has been read somewhere in the system. And if that has not been acted upon, then one should be able to pick that up and do the appropriate escalation. And this is potentially can be done in a combination by the digital system or the result coordinator team. This is a list of contributors to our work here, and is quite a big piece of work. And I'm very grateful for the contributions and the support from the Academy of Medical Royal Colleges and 6 other medical colleges, Society of Radiographers, and also our NHSE, NHSI, and the Informatics department. And also all the consultations that we receive from the patient network, lay member network, and a lot of other input as well. So thank you to all. So I'll pause here. Thank you.
Thanks very much, TC, and very generous acknowledgements at the end. And the only correct thing to do is to acknowledge your contribution. You led a very wide team, and you delivered a terrific document. So all tribute to you for your hard work and persistence.
Thank you.
We're going to move on now with the third presentation, and I think this will be you, Dan, talking about future digital solutions to alerting. So, Dan, the floor is yours.
Thank you. So rather than more slides to look at, I'm just going to have a little bit of a talk about the digital perspectives and response to the paper that's recently been released. So I'd firstly like to say what a terrific achievement it was. And in the Radiology Informatics Committee, we were glad to have a look through that and pass on our thoughts. Large-scale changes in practice are probably about 95% to do with cultural change and process change, and the remainder to do with the detail. But in radiology, obviously, technology is very important. So I think it's more like an 80% culture change and 20% technology influence, since we are quite dependent on that. But the great thing about this paper is that it gives us a set of founding principles so that different subspecialties can interoperate around a new alerting safety framework. And that's important because technology decisions need to be based on the accepted gold standard physical pathways. So we don't buy technology and decide this is how we're going to do our safety. We decide the correct safety process and then design, build, and purchase the technology around that. And to have a joint college position on that, to design the technology approach on, is really valuable, and it's the correct route.
Progress.
Now, if I focus a little bit on the technology details, we have some standards that we can look towards. We have HL7, the language of healthcare metadata, and it provides us alerting codes so that we can notify things like a patient record system or a results portal of an urgent result. And that allows interoperability between systems. But something that we noted when we were involved in this consultation as an informatics committee is that most hospitals, certainly throughout the UK, do not have downstream alerting systems listening for those HL7 messages, and they don't have messaging brokers to be able to emit push alerts to the referring individuals or the teams in charge of patients. And until we had that infrastructure in place, a pure technology approach couldn't work. The other thing I'd like to say is that retrofitting of safety is very important. And we had lots of discussion around the use of text codes. Now, I think everyone on this meeting probably uses text codes in their radiology reports, things like #alert or #critical. And these have often been damned in favor of interoperability standards. But throughout the entirety of my life, the most constant thing in computing has been plain text. And that's why we should never remove those simple alert codes. They allow human reaction. They allow a semi-automated approach by carrying out reports on the text codes, perhaps daily, and then sending out manually the reports. And they also allow a fully automated approach by text passing of the reports in real time to trigger proper alerting systems with HL7. So perfect to me looks like the combination of a good set of gold standards as defined in this document, some retrofit of old standards for text codes, and an ethos to keep adopting new digital alerting systems as we purchase new hospital record systems. But the one missing thing that I wish that all hospitals would adopt is a push messaging broker so that we can actually emit these alerts and then they're not just waiting for somebody to find. Thank you. That's about all I have to add on technology.
Thanks, Dan. That's a great presentation. And another great bit of news is that Graham Robinson, our final panelist, has joined us just before you started speaking. Graham is the NHS England Clinical Lead for Imaging Digital and IT Transformation. Graham, would you like to add anything to what Dan's just said? I know you were here for his presentation.
Yeah, my apologies. I had a terrible diary failure, and fortunately came in just at the right point for Dan. From my perspective, so no, not enormous amount to add. Obviously, firstly, thank you for all the work and the authors on that document. I mean, I know that was a lot of political toing and froing as much as anything, and getting people on board from other colleges, etc. So the amount of work within that is not to be underestimated. I mean, I suppose, my questions would be, how do we go from where we are with the document to the next stage, which is really what Dan's alluding to, is that it feels hard to me to say that we should not have an automated digital alerting system. And I think there are potential solutions that could work for that. That maybe, we're not quite there yet in terms of the refinement, but I think I would like to get to a stage in the reasonably foreseeable future where there is an automated, mandated an electronic system for alerting, because not being critical of the document, because we are where we are, but it is just, there is still quite a reasonable amount of emphasis on human interaction of human messaging, human alerts, human phone calls and so on to referrers. And it just feels that we need to make that next step. I'm not entirely sure how we do that, but I think that is really important. Dan will probably have better IT nous than me about how we can get there, but I think that's really, for me, this is a stepping stone. We need to get to the next bit. Otherwise, it will be accepted that the human side is still the sort of main solution, and I just can't see that being where we need to get to. That's all.
Okay, thank you, Graham. Thank you, Dan and Graham, for that future-looking to add to the current document. It's always important to be thinking of your next move forward, how to improve and improve.